Hi, good afternoon. My presentation is a comparison of the treatment outcomes between notched iodine plaque brachytherapy and external beam radiation in juxtapapillary choroidal melanomas. So enucleation does not provide any survival benefit in melanomas, which is why radiation, especially plaque brachytherapy, is the primary form of treatment for most melanomas. However, the standard round plaques are not suitable for juxtapapillary melanomas, which is why these tumors were excluded from the COMS trial. This is because of anatomical hurdles to placing a standard round plaque over a juxtapapillary tumor. The further advancement of the plaque is hampered because of the width of the optic nerve sheath, which, as we can see, is much wider than the optic nerve head itself. So a part of the tumor goes untreated by radiation. This led to the advent of notched plaques. This is the COMS notched plaque with a depth of 3 millimeters. At our center, we use the customized deep notch plaque with a depth of 6 millimeters and a width of 8 millimeters. On comparing the two, we can see that the COMS plaque does not encircle the nerve, whereas the customized plaque that we use encircles up to 270 degrees of the nerve circumference. So in this study, we compare the treatment efficacy and the radiation complications between deep notch plaque and EBRT in managing juxtapapillary melanomas. We included all patients treated with the two modalities between 2016 to 2020. Group A consisted of 84 eyes treated with plaque, and Group B consisted of 37 eyes treated with EBRT. The primary outcome measures were local tumor control, globe salvage, radiation side effects, and the secondary outcome measures were final visual acuity and metastasis-free survival. Tumors within 2 millimeters of the nerve, encircling less than 270 degrees of the nerve, and touching the optic nerve head could be treated with a deep notch plaque, whereas those with a radial diameter more than 15 millimeters, overhanging the nerve head, or encircling more than 270 degrees were treated with external beam. Coming to results, there were no significant difference in the demographics between the two groups, and the median follow-up period was a little more than 3 years in both the groups. There were no significant difference in the tumor characteristics either. Coming to the outcome measures, we can see that we have excellent rates of tumor control in both groups with no significant difference. At 5 years, it's 93% in those treated with plaque and 94% in those treated with EBRT. But when we look at the globe salvage rates, it's significantly higher in those treated with plaque as compared to EBRT. It's 90% at 5 years in Group A compared to only 64% rate of globe salvage in EBRT group. The rates of metastasis-free survival and final visual acuity were also significantly better in those treated with plaque. Coming to radiation complications, we can see that there's a significantly higher incidence in those treated with EBRT. The complications include cataract, radiation papillopathy, retinopathy, vitreous hemorrhage, and neovascular glaucoma. There's been another study in our center 10 years ago comparing the two modalities, but there are a few notable differences. So over the years, there's been a gradual change towards doing more plaques for juxtapapillary tumors. We've also reduced the dosage of EBRT from 70 to 50 gray and found that that increases the treatment outcome rates while reducing the rates of radiation complication. Replacing the standard plaque with a deep notch plaque has also improved the tumor control and the globe salvage rates. On comparing our rates of tumor control and globe salvage, they were comparable with that reported by other groups, and so were the incidence of radiation complications. So to conclude, both brachytherapy and EBRT are equally effective when it comes to controlling the tumor locally. However, brachytherapy provides several advantages. There's a lower rate of secondary enucleation, less radiation complications, and a better final visual acuity. Overall, this leads to better patient comfort and acceptance. So despite all the surgical challenges and anatomical hindrances, the deep notch plaque design is very effective in controlling juxtapapillary melanomas. Thank you for giving me a patient hearing.
Thank you, excellent presentation. One of the problems that's always discussed is the fractionation of the radiotherapy treatment, because if you lose 40% of eyes, that's a lot, isn't it? And you do it in one session, the radiotherapy, is that correct?
For EBRT,
yeah.
we do 5,000 in 5 fractions.
5 fractions, okay. And do you have any access to proton beam, which one would think would be...
Not yet. Not yet at our center, but they're hoping to do it soon.
Because the problem of your approach, I mean, you obviously showed excellent results, congratulations, but it is surgeon dependent, isn't it? It is not easy to put the plaque in the right position there. Have you had any problems that we are always afraid of with central retinal artery occlusion?
No, we've never had a central radiation retinal artery occlusion. In certain cases where the plaque placement was a bit difficult, we've used intraoperative ultrasound to confirm that the plaque is in the right position. So that definitely helped.
Congratulations, very good results. Thank you. We move on to the next presentation. Martina Anji, please.